started. Feel free to, no. Yeah.
Absolutely.
Yeah. Thanks everybody for coming today, and happy PA week to everybody. So I think I've met most of you in the room, but for anybody that I haven't met, my name is Kira Vader. I'm the Chief PA here at UWMC. Here in our system, we have just over 100 PAs who are credentialed through UWMC, both inpatient and outpatient, so there are a lot of us. And we're part of the larger advanced practice provider group, so we do quite a lot with our ARNPs and our CRNAs as well. So we just want to thank everybody for being here. This year's PA Week is a joint project between the UWMC PA Association and Medics Northwest, which is our PA program here at UW. We have a bunch of our students here today. And just wanted to thank Medics for providing the nice lunch for us. And thank Mr. Turnipseed for being here today to speak with us. It's a real treat to have someone from the very first PA class here come and talk with us today about all the things that he's seen throughout the many years of his time in practice. So, and then also thanks to our communications team led by Dennis for putting together the slide set for us. This is also going to be live streamed and recorded, so if you want to watch it later, you're more than welcome to. I see Dr. Stager, our medical director, just walked in the back. Thanks for being here, and we appreciate you supporting all of the advanced practice providers here at UWMC. So, and then Terry Scott, most of you know, is our PA program director and our division chief for the PA program, and he's going to introduce Mr. Turnipseed.
Thank you, Kira. First of all, I also would like to say a strong acknowledgement for Kira, because she's now the lead PA at UW Medicine. In the last couple of years, she has put some tremendous work in these PA Week activities, and so the work that she's been doing is paying dividends. So how about a nice, just a quick round of applause. So I want to welcome everyone as well, including the dignitaries here from UW Medicine who have joined us. PA Week activities this PA Week is something special because it's the birthday of Gene Stead, the founder of the profession. It was October 6th. And so this week has significance for that reason. It also has significance for us because MEDEX is the second oldest PA program in the country. And when we look at that, and we are able to get someone like Mr. Turnipseed to join us, we're talking about several decades of experience, and only a few programs in the country can go back and have living history come in and speak to it like the MEDEX program, and so we're happy to have him here. So in terms of Mr. Turnipseed, I'd like to tell you he's a graduate of the MEDEX program, Class 1. We all know that. This program was founded by Dr. Richard Smith, graduating a class in 1969, the first class. Picture of it is here behind me. Like all early MEDEX students, Mr. Turnipseed came from a military medical background, serving in the Special Forces Medical Counterinsurgency Program. And he was distinguished and recognized for his special achievement along the Thai border, working with minimal supervision. He had an intense professionalism and military bearing which set him apart from his peers. He brought that same outstanding performance and commitment to duty to being a PA. And was one of the first graduates of the MEDEX program. He went on to become one of the first PAs employed by Group Health Cooperative. Group Health recognized his leadership ability fairly quickly, and he went on to serve as a clinic and hospital administrator at Group Health. So you can imagine being a PA leader. Imagine being one of the folks who trailblazes a new profession while at the same time being tapped for leadership. That's a pretty impressive resume. And as a pioneering PA leader, he was a strong advocate for uniting PAs under one organizational umbrella, and he's a founding member of the board of directors for the American Academy of Physician Assistants. So that's our national organization. He was appointed by the AAPA to serve on the National Board of Medical Examiners, and this was the group which was responsible for developing the first PA national certifying exam in 1973. Mr. Turnipseed also served as one of AAPA's first representatives to the Joint Review Committee for Accreditation of Physician Assistant Education, which at the time was overseen by the American Medical Association. So that's the group accrediting PA programs as well. He joined several other PA leaders at the time and helped form the American Academy of PA's Minority Affairs Committee in the early 70s. And he's a founding member of the African American Caucus of the AAPA. In addition to national service to the PA profession, he believed in working locally to foster the concept and was a founding member of the Washington State Academy of Physician Assistants, serving as its president in 1976. He was active in building relationships with the Washington State Medical Association and worked as a member of their reimbursement committee to develop policies for the payment of PA services. All these things we take for granted. Mr. Turnipseed has worked to establish other PA programs, such as at Charles Drew University in Los Angeles. He's been a consultant for the University of Alabama, the University of North Dakota, the University of Utah, Howard University, and several others. He later served on the faculty at Stony Brook University's PA program in Stony Brook, New York, and was one of the first PA educators to receive the rank of assistant professor. Mr. Turnipseed has practiced in Southern California, although he currently lives in Nevada. He continues to work part-time, travels back and forth to Los Angeles from Nevada. So, I mean, his commitment to serving the underserved communities is still there. So I'd like to have us welcome one of the first graduates of the MEDEX program, Mr. Steve Turnipseed. It's great to have you here.
Thank you. Thank you. After listening to Terry, I'm tired. But all I did in the past was actually a labor of love and something that I really wanted to do. As you know, historically, the PA profession, when we first started here in 1968, there were no dynamics, there were no rules, there were no lines, there were no areas of demarcation. So we really set out about to do this because of the idea of a person that I found as my mentor and my guide. It was Dr. Smith. Dr. Smith had the idea to develop this profession as a byproduct of his working. He was a physician who was a graduate of Howard University, and he was in public health, and he did his public health work part in the Peace Corps and part in international medicine. He worked in Africa. He worked in pre-Castro Cuba, and he saw firsthand that there was a need nationally and internationally for more access or better access to primary care, and he came up with the idea of using the physician assistants for that particular role. Dr. Smith also worked at the World Health Organization. He sat on its council and the World Health Medical Assembly in 1967, dealing with many issues related to international health and primary care. He was a very dynamic individual. His role models basically was people like Sister Teresa and Albert Schweitzer. He worked with him in Africa to help in some of the indigenous populations for health care. He was a dynamic person in himself. He had an idea of what could be done and what should be done, but there was no particular way of identifying how to do that. In other words, to find a force or to find individuals who were capable of doing this, he had to find some people that were trainable or had been trained. So he used the idea. His partner or co-founder in the program was William Freeman. This is a picture of Bill. Bill Freeman was a dynamic person. He was a Peace Corps volunteer. He graduated from Amherst College in New Hampshire. He was also a Special Forces corpsman who was trained for independent duty work. So with those two dynamics, having his experience with the Peace Corps as well as with the military, when he met Dick, and Dick told him about his idea about developing a profession that would serve in primary care, they had a perfect marriage, Early on in the PA profession, the program was started by Dr. Eugene Stead at Duke University, as well as there were other pioneers in the field like Dr. Henry Silver, Dennis Carlson at Hopkins. But all these people had a different idea and a concept about what PAs were and how they could be used. But the core was always the same. It was primary care and using the experience of former military corpsmen. The profession was new, and before the PA concept came about, there was basically the idea of a physician-nurse relationship, and that was pretty much it. So there was some resistance, or some, I won't say this, I won't overstate this resistance, but there was some issues that nursing had, particularly with the PA profession. One of the things that we confronted early on, I personally did because I was the president of the WAPA at the time, but we had actually had a lawsuit against the nurses because PAs were not physicians and they were not going to follow orders of non-physicians. And this actually brought out the uniqueness of the program that Dick developed, which was a collaborative model. The collaborative model, if you don't know what that is based on the idea that if you have people who have mutual vested interests in the outcome, then they're more likely to support your idea than resist it. So we developed this collaborative model with the Washington State Medical Association and then the physicians in the field, primary care physicians, who were working in rural areas that had really were overwhelmed by the demands placed upon them. I want to segue a little bit to the idea about the preceptorship relationship in the collaborative model. The preceptor relationship was one that was established because physicians in primary care, particularly in rural and urban underserved areas, were at their wits' end in terms of how they were going to provide care. They were overwhelmed. In small places like Twist, Washington, Wenatchee, in areas like that, there were maybe 3 or 4 providers of primary care, and there was a population of 15, 20, 30,000 people. And they were not being able to handle it. I remember going out to Twist, Washington and working with Dr. Henry, who was the physician for an area of about 70 miles around Twist, Washington. And he was saying, you know, I just can't get away from it. He says, I go home and people just drive up to my driveway 6 o'clock at night and go, hey doc, you know, I got this spot on my hand, you know, you take care of this? Or, you know, they were calling him on the phone 24/7. And they said, you know, he's got to answer the phone. He's got to be there. He's got to do it. And he was just, you know, he couldn't take a vacation. He couldn't have time with his family. And lo and behold, our idea of the medics program was almost a lifesaver to him. I mean, it really made the difference in a lot of practices that were ready to just like, one physician actually told me, he says, you know, I had planned it already. He says, I'm going to load up my trailer, I'm going to move out at night, I'm going to just take off and go somewhere else. I just can't deal with this. So lo and behold, there we came with the medics concept, and it became part of the program. So the mutual vested interest issue was very important, and the collaborative model was very important. And I get back to the issue, oh, by the way, this is a picture of Dr. Eugene Stead, the father of the PA movement. But I get back to the issue about the nursing, and so they hit us with this suit that said they wanted to stop the profession totally. They wanted to nullify this because it couldn't happen, because there would be no way that nurses would take orders of a PA, of a non-physician in a hospital. Well, they took this case, it actually went to the Supreme Court of the state of Washington, and because of our collaborative relationship with the Washington State Medical Association and the physicians, they filed an amicus brief which stated that PAs were an extension of a physician, therefore they had the same rights and privileges when delegated the authority by the physician to do that. So that took care of that problem, and it was all over. So anyway, this is a picture of Dr. Stead, who was a pioneer and a very thoughtful man. I met him several times, and I was very impressed with his ideas about how we were going to develop this profession. This is the picture of the first class of PAs in 1967 at Duke University. And later, you know, as you know, in 1968, we graduated our first class. It was interesting because when we started the class, there was no academic criteria, there was no curriculum, there was no guidance, there was no... We had to determine what we were going to do and how we were going to do it and what we were going to learn. So that was a very interesting concept, and every day was new and different. Many of us, all of us as a matter of fact, came to the program as former independent duty corpsmen who had been in Vietnam for many years. And the dynamics of the medical profession in the military, particularly with Vietnam, it was the first war that we actually fought that the medics made a significant difference in lives being saved. There was a significant difference. Because, well, it has to do with a lot of other things. It had to do with transportation and military and upgrading of the medical facilities. But the corpsmen on front line were the key to making a difference between saving hundreds of thousands of lives. And a lot of these corpsmen who were trained as independent duty corpsmen to do the job of the physician on the front line. And that's what we captivated in terms of recruiting these members to develop the program concept. I personally, as was mentioned earlier, my last duty assignment was in the 1st Special Forces Group, and I was in counterintelligence and psychological warfare, but I was also a medic in a Special Forces team. To be a medic in a Special Forces team is very dynamic because you are charged with the total responsibility of health care of your team when you're on a mission. So whatever happens, it's your responsibility, and you know you have to hold up your end of the bargain, and that's what I did for almost 10 years. When I got out, I got discharged in 1967, maybe, yeah, 67. I was thinking 66, but anyway, 67. And I went from one avenue of a combat situation to coming back to the States, and I landed in Oakland California, feeling very energetic and revived and feeling great. And when I got off the plane, I remember I was met with protesters, and they were saying things like, "Baby killer." And I remember one lady came up to me and spit in my face because she thought that I was part of the military complex. Well, that was a dramatic re-entrance to the whole situation. So at the time, I was born and raised in Baltimore, Maryland. It's outside of Washington, D.C. And I went back home. That was in February. In April, the middle of April, I woke up to hearing riots, craziness, and seeing people just running through my neighborhood, burning, looting, because of Martin Luther King's death. So the dynamic of that change between coming back to Oakland, coming back to Baltimore, and I was really complex. I was really perplexed at what was going on. What was this really about? And that was when I got a call from a former colonel in Special Forces who was at the Bureau of Health and Bureau of Prisons Health Department at Washington, D.C. And he said, "Steve, I hear you're not doing anything right now." I said, "No." He says, "Well, I would like for you to join us in a new program at the Public Health Service in Bureau of Prisons as a MTA." And that was the term they used at that time, was medical technical assistance. And what they did, they had another variation of the PA concept, but using it in prisons. So I said, "Well, yeah, I'd do anything to get out of Baltimore right now." But he says, "Well, you can do this." He says, "But it's just one catch." I said, "What is the catch?" He says, "You've got to go to Leavenworth." And I said, "Leavenworth? Oh, okay. I guess I could do that. I don't know." I mean, I didn't really understand what that was about. But anyway, Leavenworth Penitentiary is a federal penitentiary, is a maximum security penitentiary. They had a population of about 3,000 people. They had a medical staff of about 6 people. It was 3 physicians and maybe it was 9. Yeah, 3 physicians and 6 MTAs or PAs. And I initially went there and started a training program. They had a modified training program which lasted about 6 months. But my day at Leavenworth usually consisted of going to work around 5 in the morning, setting up for surgery, and we would do surgical procedures for the first 2 hours, usually elective things, hernias, rhinoplasties, whatever was needed locally we could do within the hospital. And I had a prison staff that would help in assisting that, but I was the surgical tech, and I was the person that did that. When I completed that, I did the surgical counts and went down to make rounds in the hospital. We had a 20-bed hospital, and I made rounds in the hospital and took care of that. From hospital rounds, I went to do outpatient care. All the medicines were passed to the inmates. And then, let's see, before noon, actually, I did the rounds in the cells for the people who were in confinement, solitary confinement. After lunch, I did rounds in the psych ward. We had 30 or 40 patients that were constantly in psych ward. And I had to do the rounds there, do medications, and direct things were going on. And in the afternoon, I had nothing else to do. I did the radiology. But it was a dynamic place for learning and understanding what the potential could be for a role like a physician assistant. I say that to say that after the year and a half of being there, they asked me to give a presentation at Harvard University about the dynamics at the National Public Health Conference about the dynamics of this particular work that I was doing. I did that, and actually Dick wasn't there at that time, but one of his counterparts or his friends from public health at HEW called him and said, Dick, you got to see this guy. You got to talk to him. So when I got home, back to Kansas, by the way, when I got home, someone called me on a Sunday night, I remember, and he says, hi, this is Dick. I said, oh, yeah, okay. He says, I really am interested in you coming out and looking at this new program that we have called Medics. I said, oh, Medics, yeah, okay. Anyway, he tried to explain to me on the phone a little bit about the dynamics of what he wanted to do and where he was going. And I took it all in and I listened. And then I went back to my colleagues, the other 6 or 8 guys at the prison, and I said, hey, I got this guy on the phone, I'm talking to him, he's telling me all about this. And they all looked at me and said, are you crazy? I said, no, I'm not crazy. He says, yeah, you are. He says, because that'll never fly. He says, you know, once you get outside of this prison where you have the protection of the federal jurisdiction, there's nothing to cover you. And no person, no doctor, no nurse, and not even patients would accept anything like a PA. Well, we didn't even call it PA at the time, we just would accept that outside. He said, you just can't do that. People don't want that. He says, okay. So we had the discussion over 3 or 4 days, and I made up my mind that I was going to go do this. And they said, well, okay, Steve, we expect you back in about, about 3 months, you'll be back here because, you got a GS-18 and that's pretty high and, you just can't get out of this, So anyway, the dynamics was that I went and I met with this guy. I mean, Dick is a unique individual in himself because he was so passionate and he was so knowledgeable. And he just, I don't know, it's like when he talked, things just sort of happened and people believed him. And they did, and they followed him. And he became my mentor, and I followed him, and this is how we got to where we are. This is a staff meeting that is Carolyn Robbins. And the second person here is Dr. Ray Vath. He was a community psychiatrist in the first class, and I'll get to him a little later and explain it. The other person next to him was Kenny Roth, who was the executive director of the Washington State Medical Association. And the other person here was Jerry Bassett. He was our first medical director. And Mark McCurian, who was our first administrator for Medics. He was a public health service person. And there was a secretary, Lauren, and this was Dick Smith. But they constantly, every day, had meetings about where we were going, how we were going to do this, how were we going to lay the groundwork, what we were going to do. And they also spent a lot of time dealing with the students, how the students were going to be perceived and what we were going to do and how we were going to learn and where we were going to go. And this is the mug shots we took. This is, yeah, those are interesting. I always marvel at the idea of seeing myself with hair, but, but at the time it was really important to me to have hair. But, And the second person is all of these guys are very close friends. As a team, we became almost one. When somebody had a problem, we all had a problem, and we all worked together. It's Mark Patterson, Bob Woodruff, who is very nice. It's John Betts and Paul Snyder. These are the surviving members of Class 1. And I think actually 3 of us are still working, including myself. I still work once a week, whether I need to or not. But interestingly, somebody asked me one day, said, Steve, when will you know it's time to retire? I thought about it for a couple of weeks, and I said, I know. And he says, how do you know? What is it? What's going to happen? I said, well, you see, what's going to happen is I'm going to go back to Vegas. I'm going to fly into LA like I usually do, and I'm going to come to the clinic. And as I'm coming to the door, as I get ready to push the door, somebody's going to come out and say, it's okay, Steve, we got it. It's okay, Steve, we got it. We don't need you today. Oh, well, but wait a minute, I got to do it. But anyway, the conversation of retirement comes up quite a bit sometimes with me in discussing things, but basically I just don't see it yet. Okay, this is one of our first classes, and actually I believe it was in this particular building. We were doing orthopedic sessions, and we had academic training. One of the dynamics about our academic training was that we tried several approaches. One was, Jerry Bassett said to us one day, so why don't you guys just go over to the second year medical students class. They're having a class at about 10 o'clock. You go over and sit in and see what you can learn. Well, we did. We went over there and we sat there for about 3 days dutifully, and we came back and said, this is not this is not what we need. This is not what we want. This is not what we really need. It doesn't really pertain to where we all want to go. So they sat down and redesigned the curriculum, and we came up with some ideas. And part of it was, in my class of 15 people, there was a surgical specialist as a PA. There was a cardiologist. There was a pharmacologist. We also had dermatologist. So we actually taught each other what we really needed to know based on the dynamics of what you do in practice, opposed to all of the other things. So it was really great. It was a great thing to do. This is one of our daily, was it daily or maybe it was weekly? We had weekly what we call debriefing sessions. And we would all sit around and we would talk about the dynamics of what we did. And I often wondered back then why we had a community psychiatrist on our staff. And I understand now that really part of what he did was help us in reintegration. He helped us with issues dealing with PTSD. He helped us in understanding how to make a new dynamic in a profession that was going to be resistant. He helped us understand what our role was and how we could develop it. And it was really great. I mean, I couldn't have asked for a better support system than what we had with medics at that time. Again, this is Roth Kinney and Jerry Bassett and Dick Smith doing a brainstorming session, and we often had those in many, many times of doing things. So we went through the academic portion, and we decided to go on to the preceptorship phase, and this was pre-preceptorship phase. All during this process, by the way, there was no enabling legislation or concept about what a PA could do or what a PA was. So all during the training, often Dick would remind us, well, you guys know you got to make sure you have other options because this may not happen. This may not happen. One of the things, I remember having that discussion, we talked about using veterans benefits, VA benefits. And Dick said, no, I don't think we should do that for this program right now because you may need those options later because this may not happen. So we went through the whole training program, the whole concept, the preceptorship, the everything. And lo and behold, we were supposed to have our graduation in April. We had to delay graduation because we didn't have enabling legislation. And this is where Dick and Kinney and Roth Kinney and other people and the legislature got together and they implemented the enabling legislation in June. So that's why we graduated in June. But we were already in practice and doing what we did very, very well. But that's the way it worked. It helped a lot that we had a lot of national attention. We had Life magazine, Time magazine, Good Morning America. I mean, it was everywhere. People were talking about the dynamic, the whole new thing about what's going on, particularly in rural places like Washington State, and how this profession was making a change. The first change in healthcare in over 100 years in terms of professions development. So it was a big thing. It was a really big thing. It made a lot of sense. That article, once a medic, now a medics. By the way, medics is a extension of a French word, medicine extension. It's a combination, med-dex, medicine extension. Okay, this is Bob Woodruff with Dr. Gammon in Cheney, Washington. They had really, really a great, great relationship. And the other thing about our preceptorship phase and the dynamics of it was that we became mutually dependent on each other. We understood what the needs were of the physician and the needs were of the PA, and it made a very big, big point. So it worked very well. And this is John Betts and Dr. Purcell in Othello, Washington. John was a former Navy corpsman who was in Vietnam for 6 years, actually. But, yeah, it was a very good dynamic. So we're back to the beginning.
All right.
It's okay. It's okay. I'm actually using the cues, so public health service. So anyway, I'm going to let him get that all together, but being a pioneer had great advantages and opportunities for myself as a person, because no one had set the ground rules before I came. We had the opportunity to do it the way we wanted to do it. We had an idea of what we wanted to do, where we wanted to go, and we did it. So I found it extremely exciting. That hair is just really something. Wow, it's great. Yeah, group health, and it was humbling, but it was a great opportunity at group health. They named an award after me. It was the Stephen Turnipseed Clinical Excellence Award for mid-level professionals. And I think, during the 10 years that I actually worked there, we made some impacts, we made some changes, we made some dynamics. And it was really significant. It was really significant. And as Terry had mentioned earlier, part of my term there, I was a Central Region Administrator, so I could have an opportunity to actually set in motion a lot of the ideas for the dynamics of the profession that I wanted to have. So, in summing up, these are the three the three PAs at Group Health. Is Cole, Charlie, and myself. And we were the urban PAs of the medics profession. So in summary, I'd like to say that I think it's been a great ride. It's been a great opportunity. I'm more than overwhelmed at seeing Class 50. And much more to come, and much more to come. I think your future is well planned, and I think you're going to have an opportunity to make new dynamics, make new inroads, make new changes, to create things in this profession that haven't been done yet. I don't think we got it all right yet. There's a lot of opportunity, there's a lot of things to be done, not only in primary care medicine, but into the social, the economical, the political, and environmental factors of practice of health care. As the new providers, you have the opportunity to do that and bring about the change that we all well deserve. I want to take an opportunity to actually give you a chance to ask any questions or ask anything I didn't cover that you wanted to know about at this time. Yes?
One of the things that at the beginning of the profession, that when you're sending students out to these places, they had to have preceptors pre-arranged. And did you have a preceptor at Group Health that was pre-arranged for you? And
Yes.
who was that?
It was Bob. It was the three Bobs at Group Health. It was Bob Sherry, Bob Stever, and Bob Monroe. They were all former Peace Corps volunteers and understood the concept that we were trying to develop and were willing to open their practice to do this. And it was interesting, I remember Dr. Stever, when we first started the preceptorship program, we actually required the preceptor to introduce us to the patients. So when we go in the room and he said, hi, I'm Bob Stever, you know me, I'm your doctor, and this is my PA, Steve, and he says, in other words, I'm God, and this is my son, Jesus. And it was many dynamics that Bob and I worked very close together. I mean, we were really we did a lot of things together, including demonstrate against the war, but on our lunchtime, we did community volunteer clinics together, I actually became the Minister of Health of the Black Panther Party in Seattle, which was not looked well upon by Dick, but it was interesting. So yes, it was great dynamics, and those dynamics made a big, big, big difference.
Well, I work at Group Health, and I think we're all very grateful that they named the award after you for the mid-level provider.
Yeah.
It was a great recognition. So
I was
laying the groundwork.
I was very humbled by that. We did a time motion study after the first year of my work at Group Health, and we showed that we had the efficiency of 90% of what physicians were doing in terms of what we did. So it was really great. We also made some dramatic changes because they have the urgent care, or the ER. Well, the ER has a separate side now, but the urgent care part, all the family physicians had to rotate on that schedule. And they really hated that because it was like cutting into their free time. So when the PAs came aboard, we just basically took over a lot of that responsibility. And over the period of about 3 or 4 years, they said, oh, wait a minute, we got to stop this. This is not good. This is not good. And we said, why? What's going on? I said, well, all the physicians are atrophying their skills because they're not doing this anymore. It's only the PAs that are doing it. So we sort of mixed it up a little bit more. So it was a lot of dynamics that went on a daily basis. I mean, it was always something new and something different and something challenging. Any other questions? Yes.
I'm talking about developing the profession a little bit further. Where do you see that going on an international level?
Excellent point. I had the opportunity to actually go to Australia in Dick's Place, actually, a couple years ago, and they are moving the program in great force. Not only in Australia, but I think, well, Dick's program out of University of Hawaii did a lot for international health in terms of developing mid-levels at, not necessarily at a PA level, but mid-levels independence in many countries. In fact, his training novels, correct me, Terry, how many languages is it translated into now?
I think it's 5.
5 languages. So, you know, the dynamic goes on and things move, as we see. Yes?
Can you talk about how patients' perceptions of PAs have changed over the years?
Yes. Initially, there was not a lot of reservations or hesitations on patients' level, mainly because of the collaborative model that we used, and we had the physician be the introductee to the patient. And so the patient said, well, I trust my doctor, so we'll see what happens here. After about 6 months, 8 months of work, I remember personally, my personal experience, 6 months, 8 months of work, I remember patients coming in and saying, oh, I don't need to see the doctor. I'll see Steve. It's okay. This is just something I want to take care of. He knows my problem, you know. So, no, the acceptance there is, and I think the dynamic is having good patient relationships and understanding what patients want and being receptive to helping them. So yes, it's fine. And I remember we also emphasize, I know that you wear white coats now, but when we first started the class, we tried to separate ourselves by wearing blue coats so that we wouldn't be mistaken for physicians per se. And I remember every time I saw a patient, I went through this whole litany of things like, yes, I'm Steve Turnipseed, I'm a new professional, I'm a PA, I'm a medics, and I'm with the University of Washington, blah, 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 blah. And the patient would go, oh, yeah, okay, yeah, I understand. And this one lady was very impressed, you know, with what I did, and she said, oh, thank you, Dr. Medics Turnipseed, I appreciate what you did. But it wasn't enough that she said that to me. She actually, in group health, you know how you go down the corridor in the halls, and it's like several physicians' sites there? And not all of the physicians were on board with this whole idea, right? But, and she got way down to the end of the hall, and she says, oh, thank you, Dr. Stephen Medics Turnipseed, I appreciate it. But that was something, yeah. So the dynamics of acceptance is the least of the problems you have. As long as you have competence, enthusiasm, and skill, you're going to be fine. Question?
Just briefly, in that time, given the way things were in the country,
Mm-hmm.
did you ever, and then the medics, profession was new to you, did you ever sense race as being an issue? And if you did, were you able to differentiate it from being a medic as opposed to, how did that dynamic work?
Well, the dynamic for me was always an issue because, well, like, I chose to go to group health because it was in an urban environment. I remember doing several preceptor site visits because what we would do, we would go to school during the academic phase from Monday to Friday, and Friday night we would take off and go to wherever the sites were and do a weekend with the physician to get an understanding of what was going on in the practice and what was happening in the area and the whole thing. I remember I went over to Twist, Washington, and I was late Friday night, so it took me about 3-4 hours to get over to Twist. And I remember going to this one winding road up to Twist, and the police light lit up behind me. And I'm going, oh, I don't know what I did. I'm like, oh my goodness, what's going on? And a guy pulled me over, so the guy came out, and the sheriff came out from Twist. He says, Steve, how you doing? I knew you were coming, so I'm here to take you in town and show you around. And I was saying, oh, okay, right. So anyway, we pulled up in town. I parked my car. He says, come on, I'm getting the car. Doc Henry told me to show you around because, you know, we want you to be comfortable here. And he was showing me around. He says, I said, yeah. He says, that's Bill. Oh, yeah, don't worry about him. I lock him up every Friday. He gets drunk. And that's Charlie over there at the grocery store. And anything you need, just go in there and tell him you're with Doc Henry. He'll give it for you, you know. And that's Sam at the pharmacist over there, and he does this and he does that. And so we were going through town. I said, by the way, are there any black people in this town? He says, oh, yeah, we got one. But don't worry, he lives up there on the other side of the mountain over there. He doesn't bother anybody. Don't worry. He said, if you ever have any trouble, let me know. So it was those kind of dynamics, I mean, that were very prevalent in this situation. In terms of race, well, at group health, you know, certainly my population of patients there were 90% Caucasians, and had little problems. I didn't, you know, the ones that we did encounter, we actually dealt with right away, particularly with Bob Stever, who was my preceptor. I remember the first time we decided to go over to the cafeteria and have lunch in the doctor's lounge. And it was an issue for a lot of doctors as to, I don't know if it was me or if it was the PA profession or what it was, but there was an issue. But he dealt with it, and we haven't had a problem since. So yes, it's something I did have to deal with. Any other questions or concerns? Anything I haven't covered that you want to know about?
So Steve, why don't you tell us about, or at least I've heard that you were instrumental in helping one of the urban underserved community clubs get started here in East Area.
Yes,
Speak about that.
that's an interesting point. One of the things I did later, after I worked in clinical medicine for several years at Group Health, I told you I became a central region administrator. And it was there that I implemented the ADAPT program, which is the alcohol drug treatment program at Group Health. They had never had one there before. And the dynamics were so clear. I mean, if you did the epidemiology, you looked at, what I did was I looked at the emergency records of about 300 patient visits. And I extrapolated that 80% of those were due to substance abuse. I mean, they were diagnosed or written on the chart as low back pain, headaches, all kinds of medical diagnoses, but they really didn't look at the issue that this was an alcohol and drug abuse problem. So when I pointed that out to the administration, we decided that we would develop the alcohol and drug program, which is still in existence. So anyway, when I was an administrator there, I got a call from the Seattle Health Department. Seattle Health Department, Public Health, asked me if I would be the South Central Area Public Health Officer. And I saw it as a dynamic, a challenge, a new change, a new thing. I mean, personally, I guess a lot of my life has been about things when people say you can't do it, I can do it. And I want to do it. And I did it. So I actually became part of the Seattle Public Health Department. I was a public health officer for South Central. And one of the things we needed to do was develop a community clinic. It took about 4 years of development work, working with the city council, working with the community, and we finally got a clinic there in South Central Seattle. And one of my, I've got, I don't know, in my office at home, I've got a wall full of accolades, diplomas, and things that people compliment me on. But my most cherished one is one that they made out of scrap paper and toilet paper and other things together. It says, Clinic Hero for South Central. And it's signed by every person in the community who is a part of that program. So those are the kinds of dynamics that you get, or you can get, when you do this profession and you do it well, because it's the most satisfying thing I've ever done in my life. Okay? Any other questions? You sure you don't get to see a dinosaur every day?
What was it like being a provider during the AIDS epidemic?
The AIDS epidemic? Yes. At that time, I was working in Los Angeles. And I actually went back to University of USC because they had a program developing for training PAs in how to deal with AIDS patients. And it was very interesting because, you think, well, you have a patient, you get a diagnosis, you get the lab work, you get all the information, and you say, oh my goodness, you got HIV, okay. Let's get you into some kind of treatment. But it's just not that simple. When you're telling someone something that's going to potentially be the end of their life, that is non-reversible, that's non-changeable. So you have to have some idea about how to do those dynamics and how to do it. And since then, we've gone on to develop AIDS clinics that just treat those problems. So yeah, it's been a real dynamic. Yes?
What do you think the next big thing will be for the PA profession? As far as either changing the role, adapting the role, widening the scope of practice, what's the next huge
Yeah.
thing?
Well, it's a lot of moving parts, and there are a lot of dynamics to it. I mean, we still got traditional medicine and the medical school concepts, and we've got other professions that are seeing this as an opportunity, considering nurse practitioners and other purses mates and other people. But I think the future of this profession is going to be what you, Class 50, see in how to do that. Because you still have the opportunity to set forth and move into the direction of what you want to do. And I was talking to students at USC recently, and they asked me, how do you know what it is you want to do and where you want to go? And I told them that they need to find the oomph. They said, oomph? What the heck's the oomph? I said, the oomph is something that you dream about before you go to sleep, and you wake up in the morning saying, I'm going to go for my oomph today. And you go about your day looking for the oomph. The oomph, you're going to find the oomph. You are going to find the oomph. You're going to find the oomph one day when you're in clinic and you see an ophthalmology exam and you find some findings that haven't been found in 20 years. And you go, oomph, that's what I want to do. That's where I want to go. I want to perfect this. I want to work with this. I want to do this. And the oomph can be also social. It can be an environmental issue. It can be looking at a homeless person and saying, you know, there could be something better we can do with this people. So finding your oomph is being able to do something that you enjoy doing and you want to do and you're good at. And that's what's going to change the profession. That's what's going to change the profession. I don't think there are any... The good thing about this profession is that, well, right now there are ground rules and there are limitations and there are restrictions and there are things that pretty much set the pattern. But you still have an opportunity to break the ceiling, to broaden the perspective, to do things that you want to do. So use this as a vehicle to make that change, and we will see it happen. Okay? Anything else? Okay, that's it.
I would love to get a picture with the class 50 students and our class 1s
Okay.
student here. So come on up front if you guys wouldn't mind.
We're going to do